Right. So, good day to our esteemed speakers, respected panelists, key opinion leaders, and distinguished healthcare professionals, and all participants. So, myself, Payal Chatterjee, the Global Marketing Associate for Oncology and Biosimilars from Heterospart, welcoming you all for today's scientific webinar on sequencing and synergy, maximizing irinotecan-based therapy with bevacizumab for the treatment of colorectal cancer. Now, as we know, colorectal cancer remains a major global health challenge, and optimizing treatment strategies are essential to improve patients' outcomes. Advances in systemic therapy has demonstrated that thoughtful sequencing of therapies and the synergistic use of chemotherapy with targeted therapy can enhance the efficacy while supporting individualized patient care. So, in today's discussion, we will focus on the clinical rationale and practical application of irinotecan-based regimens in combination with bevacizumab across the treatment continuum. Our expert faculty will review current evidences, real-world experiences, patient selection, sequencing considerations, and approaches to maximizing clinical benefit. We are privileged to have renowned clinician and researcher as international speaker, along with eminent panel of experts from different parts of the world, who will share their valuable insights and address participants' questions during the interactive Q&A session. We encourage everyone to actively participate and make the most of this opportunity for scientific opinion exchange. In this regard, requesting participants to scan the QR code on your screen to provide your insights for pre-survey questions. So we really appreciate all of you joining us and contributing to this important conversation. We hope you find today's session informative, engaging, and clinically relevant. With this, I hand over the session to our moderator, Dr. Payal Desai from Medical Affairs team, to begin this scientific event without any further delay. Over to you, Dr. Payal.
Thank you. Good morning, good afternoon, and good evening to all. A very, very warm welcome to all of you. It's wonderful to have you all join us. I'm Dr. Desai, the medical lead for oncology with Hetero. For the agenda, today's program has been thoughtfully designed to include an expert presentation, an interactive panel discussion, and a dedicated Q&A session. The chat box will remain open throughout the webinar, so please feel free to submit your questions at any time. We will address as many of them as possible during the Q&A session. It is now my distinct pleasure to introduce our esteemed international speaker, Professor John Bridgewater. Professor Bridgewater is Professor of Medical Oncology at the UCL Cancer Institute, University College London, and Consultant Medical Oncologist at University College London Hospitals in the United Kingdom. An internationally renowned expert in gastrointestinal cancers, his work spans colorectal, biliary tract, pancreatic, and upper GI malignancies. He has led numerous landmark clinical trials, contributed extensively to global treatment guidelines, and has been at the forefront of advancing targeted therapies and precision medicine in GI oncology. We're truly honored to have Professor Bridgewater with us today and look forward to benefiting from his invaluable insights and extensive experience. Without further ado, Professor Bridgewater, the virtual stage is yours.
Thank you very much indeed, Payal and Ashmi, for setting this up. Really looking forward to the discussion and talking you through what is a really exciting area in GI cancer at the moment. So this is going to be about irinotecan-based therapy with bevacizumab for locally advanced and metastatic colorectal cancer. Should be able to. There we go. So colorectal cancer is a huge global burden. Almost 2 million new cases a year, about half of whom will die. So about a quarter of patients present with advanced disease, and another quarter of patients relapse after curative surgery. So we've still got a long way to go in terms of improving our numbers here. Eastern Asia is the highest disease burden, with China contributing a large number of cases, and this accounts for about colorectal cancer accounts for about 10% of all cancer deaths, which in the world, which is a very, very large public health burden. And the incidence is increasing. And this is at one stage, this was thought to be related to improved diagnosis and the changes in the international classification of disease coding. But in fact, there is a real increase as well. And this is undoubtedly because of lifestyle factors, obesity, exercise, diet, multiple factors about which we really do need to do a lot more work. Exercise is really the only one we've made any headway into. This is a fascinating area which I'm sure we'll hear much more about. But actually, there's more of it around, is the key message. Now, so how do we consider metastatic colorectal cancer? So there are, as I said, about a quarter of patients who present with metastatic disease. Amongst these are also patients who we think of downsizing. So these are the patients with advanced disease that may become resectable following systemic therapy, what we call conversion therapy. That is an increasing number depending on where the disease is and what your local pathways are. There are patients who have resectable disease, but actually you can't do the operation because they're not well enough. And of course, the largest chunk of these patients are those patients who require palliative treatment from the start. And this takes you through the staging of colorectal cancer. So stage 1 within the wall, stage 2 invasion through the wall, stage 3 into lymph nodes, and stage 4 distant disease. And this is and there are, you can see there are multiple molecular markers and molecular disturbances that accompany this evolution of disease. This process, we know from the polyp studies, actually takes something in the region of 20 years, depending on the genomic background. So really, the understanding of this is critical in terms of prevention policies in the future. And of course, here this says it's more than one disease. It's many diseases, in fact. Here we've divided it into two groups to consider. So one is the anatomical and demographic description of it. So right versus left, we'll go into that a bit later. That's a fascinating thing. Young versus old. Are young patients presenting? Is that a different cancer to old patients presenting? The answer is probably yes. The stool flora. So this is the microbiome, the impact of the microbiome on the control of the disease and synergy with systemic treatments. That's a really growing area. Still at the moment, I would argue, somewhat experimental. The molecular growth is huge. There'll be a little bit more as we go through as we look at the ESMO guidance a bit later on. And here we have 4 examples of the molecular subtypes that you can have in this cancer. Actually, it's more than that. There are multiple subtypes, and each of them getting an increasing profile. So what helps us decide how to treat a patient with metastatic disease? Well, there's the patient themselves, how fit they are. There's the amount of cancer that there is, the tumor burden. There's the molecular characteristics. And then there's what the patient wants. Does the patient want to have a chemotherapy that potentially gives them neuropathy or makes them lose their hair? These are all important questions, and out of this list of options, we should be able to get the perfect menu for every single patient. And for every single patient, that is inevitably going to be different. So here's an example. So it's a 38-year-old man with really extensive disease, primarily in the right lobe, arising from a sigmoid primary. You see there, that's the third picture on the right. Here's another patient with a slightly less advanced disease in the right lobe, and here is another case of a 65-year-old man, and who presented with constipation, abdominal pain, bloating, and weight loss. And this really harks back to what we use in the UK, and I think is used in many places internationally, and that's the NICE guidance for diagnosing cancer. So if anybody comes to you, not necessarily oncologists, but general physicians in the audience, with an abdominal mass, change in bowel habit, iron deficiency anemia, abdominal pain, rectal bleeding, or weight loss, any one of those and or a combination, the most common of which is a change in bowel habit, you should go ahead and have a FIT test. So this is a very sensitive test to look for blood in the stool, and will then precipitate a further series of investigations to confirm or exclude the presence of colorectal cancer. And the workup is pretty standard. I probably don't need to go through all of this, but for this particular patient, they were anemic. The liver function, unsurprisingly, was elevated. The serum CEA was elevated. That's controversial to the extent to which that's a reliable biomarker. The diagnostic test, the colonoscopy, found a mass at about a 5-centimeter mass in the sigmoid, and the profile suggested that this was a KRAS mutation. Notably, I mean, this is given as a real-life example. Just to say a KRAS mutation codon 12 these days is, of course, not enough. There are multiple subtypes of it which have different indications for treatment, and we'll go into that a bit later on. So the patient had an operation. 5 nodes were found to be positive, and the tumor was through to the musculus propria and the perirectal fat. So that's a T3N2 tumor. In addition, there were multiple liver metastases and also 3 pulmonary nodules. So this patient, the final staging is T4N2 M1. Some people would subdivide that staging into M1 lung, M1 liver. I don't think there's any real point in doing that here, because clearly the patient merits probably palliative systemic treatment. And and what did this patient have? They started with FOLFOX and bevacizumab, continued with maintenance capecitabine and bevacizumab. So there's really good data supporting this maintenance schedule, originally put through by the Dutch about 15 years ago now. Second-line treatment with FOLFIRINOX bevacizumab. You'll notice that the partner is a VEGF inhibitor, bevacizumab, because of the RAS mutation. And then third line, the patient had regorafenib. That's one of several third and subsequent line treatments we now have available. And that's essentially reflected in the ESMO and NCCN guidance. Personally, I followed the ESMO guidance much more closely. The NCCN guidance is more a list of what you can do rather than thought through recommendations, in my view. The ESMO guidance is a much better thought out piece of work. Of course, there is no to say the KRAS is just one of multiple molecular abnormalities that are becoming increasingly actionable. So if we go around this little circle here, wild type patients merit EGFR therapy in addition to chemotherapy. BRAF patients now merit BRAF treatment. So most recently, the breakwater data suggests that the addition of encorafenib and cetuximab is hugely beneficial. Non-BRAF 600E mutations are currently not treatable. MSI, huge amount of data out there now, both for NeoPrism and the Dutch studies suggesting immunotherapy is in a large number of patients curative. HER2, that's perhaps lagging a bit behind, but studies using trastuzumab deruxtecan and other HER2 targeting agents increasingly important. MET amplification, so that's a little bit behind. Pole mutation and a small number of fusions. So, for instance, lung cancer, the treatment is now dominated by first-line treatment of genomic fusions with small molecules, incredibly successful. That's less of an issue here for colorectal cancer, but nevertheless one that we should not forget. And then there's the continuing argument, and I would say it's a big argument, about right versus left-sided treatment. So for some reason, and we still really don't know why, right-sided patients do not respond well to EGFR inhibition, even if they are RAS wild type. And there's been a huge amount of work looking into this. Nobody is entirely sure why. And indeed, there are no level 1 data supporting it. But for the most part, right-sided patients are not treated with EGFR inhibitors, rather VEGF inhibitors in first line. So you should add those. They effectively behave like RAS mutated patients. Quite a few of them are RAS mutated, but they, even if they're wild type, those patients do behave like RAS mutated patients. So it's very important not to give those patients EGFR inhibition. And these are the pathways for local regional and then first line treatment. And you can see, I hope you can read it. The local regional treatment has all got to do with downsizing the systemic treatment, normally with just chemotherapy followed by surgery. I think that's a fairly straightforward situation. Whether a patient has local regionally resectable disease, for the most part liver disease, is up to you in your multidisciplinary meetings to work out. There are, however, as we said earlier, a large chunk of patients who only have irresectable disease for which systemic treatment should be considered. And I'll walk you through the boxes here because they are actually quite important. The first thing to determine is whether your patient is mismatch repair deficient. If they are, immunotherapy with either pembrolizumab or ipilimumab and nivolumab is curative in a large number of patients, and it's a fantastic breakthrough, really, in the last 3 or 4 years or so. The reasons why are all around neoantigens and the ability of these checkpoint inhibitors to treat neoantigens. This is likely in your advanced disease setting to be only around about 4% of all patients. The vast majority of your patients are on the box on the right here, are mismatch repair stable, and they are either eligible, in other words, fit enough, or not fit enough for treatment. If they are, you further break that down into RAS mutated patients who should really have chemotherapy and VEGF inhibition with bevacizumab. BRAF mutated patients should have the encorafenib cetuximab combination with chemotherapy. And down on the right-hand side here for the wild types, bevacizumab chemotherapy should be considered for the right-sided primaries. And it's only the left-sided primaries who should have EGFR inhibition. And that's become really completely crystal clear over the last few years. And this is the third and subsequent line therapy. And here we come across all the molecular subtypes that I mentioned earlier, the HER2s, the rare fusions, NTRK-RET, are very important, but if uncommon treatments. And then in terms of further treatment, well, there's bevacizumab together with Lonsurf. That's become really the third-line standard of care for a large number of people. And then there are also the options of fruquintinib and regorafenib. And for the most part, most clinicians these days mix and match those options after a full conversation with the patient. And this is much the same thing. Second and third line, you can see that bevacizumab features strongly across here. I put a question mark over here over the issue of adagrasib. Just last week in Munich, the adagrasib second-line adagrasib study was presented and was in fact negative. So sadly, this guidance is already out of date and should be changed. Adagrasib really probably not a role in second-line treatment, perhaps a role in third-line treatment. So irinotecan is one of the key backbones. What is it? It's a cytotoxic drug. It's a topoisomerase 1 inhibitor, induces double-strand breaks, and this results in tumor death when the cell decides to divide. It's the basis of regimes like FOLFIRI, which is infused 5-FU with irinotecan, Xeliri, capecitabine with irinotecan, and FOLFOXIRI, which is oxaliplatin and infused 5-FU. The primary issue with delivering these combinations, these cocktails, is the toxicity overlap and what toxicity the patient has and the potential safety of giving the patient this particular treatment. Bevacizumab serves as an excellent accompaniment to all of these options because it really has a remarkably good safety profile. And we know from the studies, I'm just coming to that, will add very significantly to the overall survival of your patient when the treatment is given on a palliative basis. So here's the breakdown of the irinotecan-based regimes, and we'll start with really what many people would consider to be the international standard, which is FOLFIRI. So it's the backbone of treatment, and you can use it with VEGF inhibition, bevacizumab, or EGFR inhibition, cetuximab or panitumumab. It's a 2-weekly regime with infused 5-FU, so it's a 48-hour infusion. Because actually the infused 5-FU, took the French 20 years to work this out, is probably the safest, most effective, and most well-tolerated regimen. It requires central venous access if it's going to be given as a day case, which is the case in most Western countries, although I appreciate in some places this is given as an inpatient. The primary toxicities are neutropenia and diarrhea, and UGT1A1 polymorphism, we'll come to that with the patient in just a moment, may be important. I'd be interested to know from the audience who routinely tests for this. We are currently not doing it in the UK. Maybe we should. So so I'll now go through some of the studies supporting the long history of how FOLFIRI has become standard of care treatment. This is a key one. This is the FOLFIRI versus FOLFOX study. So people started with one, went to the other, and then crossed over, and essentially they're interchangeable. How then do you decide between first-line FOLFIRI or first-line FOLFOX? We normally leave it up to the patient to decide, but either is acceptable, and for the purposes of this conversation, FOLFIRI is an extremely acceptable first-line option paired with bevacizumab. There are, of course, other ways of giving irinotecan. One is in the FOLFOXIRI intensified population regimen. We'll come to how good or not that is in just a minute. The 2-weekly regimen but if you use the 3 drugs, it's got more side effects, no question about that, and only really should be good for fit patients. It's said that this should be given in aggressive or high burden colorectal cancer, although personally I'm not sure that there's a lot of evidence for that. The general feel for using FOLFOXIRI is still, I would say, one of patient and clinician preference. Here's some of those data. So this is the GONA study. This is one of those Italian studies comparing FOLFIRI to FOLFOXIRI, and there are both progression-free and overall survival advantages. Has to be said, this study is an outlier. Most of the other studies, including the ones I'll move on to in a second, do not show this overall survival advantage, although undoubtedly there is a progression-free survival advantage. What about Celery? So this is capecitabine, oral fluoropyrimidine together with irinotecan, and many people use this for the sake of convenience because it is clearly much more convenient to take tablets rather than have a bottle attached to you for 48 hours. And it is given once every 21 days, although there are some places that use it on a 14-day regimen. The difficulty with it is the toxicity, and the studies using Celery have generally come across really quite significantly increased diarrhea primarily and hand-foot syndrome, and consequently very few people use this. It's rarely used in the UK, primarily for those reasons. What about bevacizumab? Bevacizumab is a VEGF inhibitor, monoclonal VEGF inhibitor, and was approved for use in metastatic colorectal cancer in the USA around about 2004, so over 20 years ago now. It has become the cornerstone biological, and on the basis of really robust clinical trials that I'll come on to in just a second. It works by neutralizing VEGF, and this has subsequent impacts on the vasculature into the cancer. One, it's been demonstrated that there's improved chemotherapy delivery, so 5-FU and the paired drug, oxaliplatin or irinotecan, are delivered much better into the cancer. The vasculature improves, and so bevacizumab can be given as a radiosensitizing agent because of the improvements in vascular effect and delivery of oxygen to tumors, and consequently the efficacy of radiation. And this is it in a pictorial way. Normally you have VEGF coming to VEGF receptor 2, and bevacizumab will inhibit that process. And once again, these are the ways in which it works. You have normal, you repair essentially. I mean, there are some fantastic pictures you can see of how the completely disordered tumor vasculature returns to something that we would recognize as a normal vascular after VEGF inhibition, and in this way overcomes the resistance caused by hypoxia in cancers. The seminal study that demonstrated this was the AVF, or in fact AVF 2017. We never called it that. We called it the Hurwitz study, which was a New England Journal paper in 2004. And the randomization was between IFL and IFL with bevacizumab. So this was bolus fluorouracil together with irinotecan. And the result was really very dramatic. The IFL and bevacizumab patients, the median survival was in the region of 20 months compared to under 16 months for the non-bevacizumab arm. And these data were what led to the FDA approval and the widespread adoption of bevacizumab internationally. And really, there's no dispute about it. These were extremely good data. What's come next? Well, people have tried to improve on that. I would question whether they have actually managed to improve on that. One of the attempts is this study, TRIBE study. So this is an Italian study, primarily from Pisa and parts of northern Italy, and it looked at two drugs, FOLFIRI versus FOLFOXIRI, both with bevacizumab. And really the question is, does upping the stakes in terms of your drugs, knowing that you will also up the stakes in terms of toxicity, does that improve your outcomes? And this is less convincing than the GONO data I showed you earlier. Indeed, I would argue I'm not convinced at all about this, because although your progression-free survival is improved, your overall survival is really not that dissimilar, 26 to 29 months. You have the other problem. That if you give FOLFOXIRI first line, you run out of options. You then have to move on to something different. You can't go to the other doublet pairing in second line. So even the Italians who wrote all of this, and I spoke to Chiara Cremolini about this, in fact, just last week at ESMO GI, even the Italians are somewhat, don't use this as a standard first-line regimen. You have to consider the toxicity of FOLFOXIRI, which is really significantly more than a standard doublet. So, and here are some data looking at celery. As I said, this is an uncommonly used combination, but one you would only really consider if you could not give safely or conveniently give infused 5-FU. So, bevacizumab recommended in both NCCN and ESMO guidelines, and really FOLFOXIRI is recommended for some people where you want to have rapid reduction of the tumor size because of the increased response rate. I think that's reasonable. I think it's still questionable about whether this increase in chemotherapy will result in an improved overall survival. The bevacizumab is the key pairing for these treatments. Here's an example of a slightly tricky problem. So here's a patient who had hyperbilirubinemia. So with liver involvement, patients are sometimes jaundiced, particularly if the extensive liver involvement, like in this patient. And in these cases, you have to move very, very carefully. So you have to give, first of all, you have to do the UGT1A1 profiling. So patients who are either homozygous or heterozygous for the alteration, you need to be very careful about giving the dose. But then you can start on a low dose FOLFIRI regime and gradually build the dose up. And this can be an extremely effective way of treating patients. And here's the patient whose disease you can see the untreated on the left, treated on the right, really very effective control of his disease with no grade 3 related symptoms. So in jaundice patients and UGT1A1 deranged patients, this is the way to go. So yeah, there's been a lot of talk about conversion therapy, so getting patients who were originally inoperable to become operable. A lot of people use the triplet, the FOLFOXIRI, for this. Bevacizumab is an excellent partner, and overall is likely to increase the likelihood of conversion of these patients to surgery. Whether these converted patients ultimately survive longer is still actually a moot point. But really, from the point of view of trying to trying to make the most of our multidisciplinary team, this is an extremely important approach. And so here's a suggestion of how to improve your induction then maintenance therapy. So bevacizumab and capecitabine maintenance therapy is an excellent, is really a very good way to go. And I've had patients on that combination for years and years. It reduces the grade 3 toxicity quite commonly and does not preclude going back onto a triple or doublet combination on disease progression. Here we have so with all our new drugs that we have now, all the BRAF drugs and all the and increasingly the RAS drugs, I haven't even mentioned the new RAS drugs that are coming along, daraxonrasib and the others about which no doubt you've heard a great deal. You have a very good problem of what to do in first line. So for instance, if you're looking at a BRAF mutation, do you give everything up front, like the breakwater combination, so chemotherapy, encorafenib, and cetuximab? Or do you do it sequentially? Do you give your chemotherapy first line, and then you give your molecular therapy, encorafenib and cetuximab second line? I don't think that's proven yet. The breakwater data are extremely promising in that the overall survival is, for that patient group is incredibly good. So I don't think there'll be a lot to shake that one up for a bit. Maybe one of you will do that for us. So what's coming up next? Bevacizumab beyond progression. There's no real reason why you shouldn't continue bevacizumab beyond progression because there's no bevacizumab resistance. It's not possible to demonstrate such a thing. Maintenance bevacizumab is an excellently tolerated regime, and particularly with the view of preserving and improving quality of life through the treatment. To conclude, the optimization of treatment involves sequencing in order to maximize survival and quality of life across the spectrum. The international guidelines are extremely helpful, but really should not replace your personal assessment of what the patient needs. That is incredibly important. The treatment intensification, I think there's a question mark over that, but certainly a lot of people do that. Bevacizumab can be considered continued line to line. I don't really think there's a question about that. And increasingly, colorectal cancer is not one cancer, but a number of subgroups of what turn out to be uncommon cancers, the smaller molecular groups which need special management. So with that, thank you very much for your attention, and we will now move on to the panel discussion. Very much looking forward to it.
Thank you, Professor Bridgewater, for the excellent presentation. We now start with the panel discussion, and we have 4 panelists with us today. Just to briefly introduce all of them to you, Dr. Randhika Rachman from Indonesia. Dr. Rachman is consultant hematologist and medical oncologist at Dr. Sipto Mangkukusumo Hospital and the Faculty of Medicine, Universitas Indonesia. Dr. Rachman has combined clinical expertise in hematology and solid tumor oncology with active research and teaching. He has contributed to studies on cancer outcomes in Indonesia and has been instrumental in strengthening the clinical management of various malignancies. Next, we have Dr. Omkhe Suprasad. She's an assistant professor of medical oncology at Srinagarand Hospital, Khon Kaen University, Thailand. She's a distinguished medical oncologist known for her research on bile duct cancer and for clinical trial work across breast and lung cancer, alongside a strong focus on supportive care and patients' quality of life during chemotherapy. Dr. Habibu Muhammad Yaqub Murtaza is the head of Department of Radiotherapy and senior lecturer at the University of Lagos and Lagos University Teaching Hospital, Nigeria. He has worked at the forefront of building radiation oncology capacity in Nigeria. He has advanced the treatment of prostate, breast, colorectal, and head and neck cancers while contributing to the expansion of modern radiotherapy services. He has also been actively involved in training future oncologists. And finally, we have Dr. Sebatu Philip Chiapo from Botswana. He's a senior clinical oncologist and head of Department of Radiotherapy and Medical Oncology at Sir Kitumail Masaya Teaching Hospital. As Botswana's first national clinical oncologist, he has played a pivotal role in building the country's cancer care infrastructure. He has helped establish Botswana's first multidisciplinary clinics for gynecological, breast, head and neck cancers, and palliative oncology, and has led the commissioning of the country's first advanced radiotherapy services. Let us begin with our first question for the panel now. So, doctors, as anti-VEGF therapy continues to evolve into a continuum of care, how do you decide which patients are appropriate candidates for continuing bevacizumab beyond progression? Yes, Dr.
Shall I take?
Yes.
Yeah, shall I take that to start? Really, this is all around toxicity. I tell my patients approximately 2% of patients on bevacizumab have some long-term or serious toxicity. It's really small, and so there really is very little. Is extremely uncommonly a reason not to continue across lines of therapy. And it's clearly recommended in the ESMA guidance to go the first, second, third line at least in this. And so I think this is, quite frankly, an easy one.
Thank you, Dr. Bridgewater. And for the panelists, what are the current guidelines in your countries, if I may ask?
Yeah, let me begin. I'm Dr. Suprasad from Thailand. Actually, in Thailand, bevacizumab can reimburse only in patient who has who is a government officer. So other than that, they need to be paid out of pocket. So in general, we only use only one line of treatment, especially in the first line in patient who has a RAS mutation, and second line if the patient has the KRAS wild type, and only in some patient that can pay out of pocket and use beyond progression, especially in patient who has a RAS mutation who cannot use the EGFR inhibitors.
I see. Dr. Chiapo?
Good. Hi.
Hi.
Well, let me just start by thanking Prof for the beautiful presentation that he gave us. Right. In Botswana, it mostly depends on the scope of your patients, if you are treating your patients in the private sector or if you are treating your patients in the government sector. And probably the only difference that it's not a difference per se. I think from this side, preference-wise and ease of giving the treatment, we usually go with the Zeliri regimen and bevacizumab, which in the private sector, for most of our patients who have got metastatic colorectal cancer, we do put them on bevacizumab with their primary chemo treatment. And for me, most of the time after their primary treatment, if we need to continue, then I'll probably continue with maintenance treatment, which I mostly give capecitabine with bevacizumab. And in cases of progression also, if I am to change to either FOLFIRI or whichever regimen, I will still continue with the bevacizumab. And also in the government sector, we do have it available. So for most of the patients with metastatic colorectal cancer, we still do use it. So I think the only thing probably that I will ask Prof later is there's really any advantage, overall survival benefit between using the Xeliri and the FOLFIRI. I think here, because most of our patients, they don't have the pots, especially in the public sector, but in the governments, in the private sector, yes, we can put them pots, and those that we can give the FOLFIRI and those other regimens. Thank you.
Thank you.
Well,
So-
in Nigeria, sorry about that.
So while they sort that out, maybe I'll answer Dr. Chiapo's question about the Xeliri versus FOLFIRI. There was a study, the big study, which demonstrated a survival advantage for the FOLFIRI, primarily because of the increased toxicity of the Xeliri. That was the reason that didn't work. I don't think there's any question of efficacy. There was just more toxicity related to the combined impact on diarrhea.
Mm-hmm.
Thanks for that.
Yes, Dr. Antika.
Yeah, in continuing bevacizumab beyond progression when for condition are met. Maybe first the patient may be clinically fit, usually with the preserved performance status and adequate organ function. And the second maybe the progression should not be explosive or associated with the rapid clinical deterioration. And the third should be no bevacizumab related with the related toxicity such as hypertension, uncontrolled hypertension, or significant proteinuria, or sometimes with the gastrointestinal perforation. And the fourth maybe must be a rational chemo switch. For example, from a sulfatin-based regimen, maybe to an irinotecan-based regimen, or the reverse. Maybe. So that's but however, I will not continue bevacizumab automatically if the patient has a rapid progression, declining PS score, or with the serious anti-VEGF toxicity, or clearly molecular alteration, maybe from the histopathology, maybe, or so maybe bevacizumab beyond progression is not automatically continuing strategy, but it's appropriate when the patient is still fit with acceptable toxicity, or the progression is not, not aggressive, or there is a rational chemo backbone to switch to. Yeah, I think that's my opinion.
Fair. So actually, if we go to
Oh.
Okay, I can go ahead and talk now. Sorry for the mix-up. So in Nigeria, most of the patients, they pay out of pocket. Not very many patients has the luxury of insurance. So for patients that are KRAS positive, we also commence with usually either irinotecan or with 5-FU or capecitabine with bevacizumab or oxaliplatin. Yes, we also do use bevacizumab as a maintenance therapy. However, not many patients are able to use it for long because of cost, because most of the patients pay out of pocket. So we usually stop it rather out of cost than toxicity.
But
it's more out of cost than toxicity, but we do use it. Thank you.
Yeah, okay. Thank you. And if we go to think of it, the treatment landscape for metastatic colorectal cancer, it's evolving pretty rapidly. There's advent of immunotherapy and targeted therapies now. So, where do you see bevacizumab fitting into this changing treatment paradigm in the coming years? Any of you, please. It's open to everyone.
Okay. Okay. I think that in the evolving era of the precision medicine, in Thailand, in patients who can pay everything out of pocket, I will do the MMR panel, RAS panel, HER2 scan before I decided to give the treatment. If the patient has high tumor burden and has a RAS wild type, I will start with chemo plus anti-EGFR because the trinket is rapid. But if the patient has the deficient MMR and can access to immunotherapy, I will do that first because immunotherapy single agent is better than chemo in patient who has deficient MMR. But if the patient do not have the deficient MMR and has the RAS mutant, I will give bevacizumab. And I think bevacizumab is still always has a place in treatment in colorectal cancer because even in later line, after you fail anti-EGFR and everything else, you still can have TAS-102 plus bevacizumab. It still has the combination effect.
Thank you.
Yeah, for me, hello. Yeah, I just a short answer that bevacizumab is still will probably remain relevant in a precision oncology, but not as a classic molecularly. I think molecularly targeted drug like EGFR or ALK or HER2 or PARP, its future role is more likely as a microenvironment directed precision therapy. So the selected patient with the IgG and vascular permeability, maybe and rational combination strategy. So maybe will still relevant in precision oncology, I think.
Thank you, Dr. Rachman. All right, let us go on to the second question, please. Yeah. So, for all the doctors again, treatment-related toxicity, it often plays a major role in sequencing decisions. How do you strike the right balance between extending survival and maintaining quality of life in your clinical practice?
Yeah, in my practice, I think that chemotherapy plus anti-EGFR seems to has a lot more side effect for patient and disturb quality of life more than chemotherapy plus anti VEGF. So I think that if I have the patient who has unresectable and don't need a rapid shrinkage of the tumor, I will choose bevacizumab plus chemotherapy first because it can preserve a quality of life better than anti-EGFR plus chemotherapy. And I think that anti-EGFR plus chemo has still have the efficacy after first or later line. So I will keep that for later. But I will use anti-EGFR plus chemo, especially in patients who has a high tumor burden who need rapid response.
Thank you. Dr.
Yeah,
Chia,
for me, okay.
Right.
sorry.
Well, we usually, even also in my practice or this side, most of the time, the side effects, yes, they will be limiting your treatment. Because how do you try to balance the side effects and also with continuing with treatment. It is always a difficult thing to do, but because also from this side we mostly use the Zeliri plus the Bevacizumab, so mostly the hand and foot syndrome that we do see quite a lot, and here and there we end up having to probably to adjust the doses for our treatment. But for most of our patients, we are able to continue with the treatment, and most of the patients, they actually do manage to finish their treatment even beyond progression. Really, when we use the bevacizumab, they still are able to continue with the treatment. It's only here and there that we have to adjust the treatment, but mostly it's because of the capecitabine than the bevacizumab.
Right. Thank you. And let us go ahead with just one. Dr. Muhammad, would you like to add it?
Yes, most of our patients are able to complete their treatment. Is when we want to do maintenance usually or towards the end of the treatment, and we either do some little adjustment or we add some other supportive therapy like pregabalin, which temporarily also could have effects on the hand and foot syndrome. But most of the time, our patient completes their treatment with Zeliri and Bevacizumab.
Thank you all. And let us take just one more question in interest of time. Ashmi, can we go to the fourth one, please? The fourth question, next slide. Thank you. So, in a fit patient with unresectable metastatic colorectal carcinoma, what factors would you consider while favoring a triplet regimen over a doublet?
Actually, in my practice, I never use triplet regimen because I think it's so much for our patient. And as the medical oncologist, I prefer to have something reserved for patient if they fail first line. So I think that only doublet plus bevacizumab or anti-EGFR if they has a RAS wild type is just enough to make the tumor shrinkage. And because colorectal is the continuum of care now, so I prefer to use only doublet. In my practice, I never use triplet regimen.
Thank you. Anyone else?
Yeah, Ms. Mayo.
Yeah.
I consider a triple regimen usually for FOXIRI and plus bevacizumab only when the patient is truly fit and there is a strong oncology reason to pursue maximal photoreduction, and also because the patient is young or because the disease is metastatic. So I will consider to divide into, with maybe we use the triple therapy because including a high tumor burden maybe, or metastatic liver dominant maybe, with some symptomatic disease and also with the rapid progressively disease. Yeah, so maybe I will use I will consider it to treat with the triple regimen maybe. Yeah.
I see. Yeah.
So most of the patients, when they present quite advanced, and many of them will not be fit to start with a triple regimen. So most of the time, we will start with Zeliri, with bevacizumab, and maybe when the treatment, if the patient is fit enough and treatment fails, it's no longer responding, then we can use triple regimen. But most of the time, we keep to double regimens.
Right. Thank you all our panelists for sharing your valuable insights and perspectives. Let us now move on to the question and answer session, where we'll address the questions submitted by our audience. We have one. How do you approach a patient with stage 3 colon cancer and intolerance to capecitabine?
Yeah, in Thailand, most of our patients seems to cannot tolerate 100% dose of capecitabine. In my practice, I will begin with 75% of the dose of capecitabine and increase if the patient can tolerate the dose. But if I escalate the dose and patient has a grade 3 hand foot syndrome, I will drop down and with that approach, I can manage the toxicity of the capecitabine.
Thank you. Okay. The next question that we have is, would like to have your comments on the usage of FOLFIRI and VEGF combination with or without trifluridine in the treatment of refractory MCRC. Also, if this combination is better suited in the treatment of refractory glioblastoma versus regorafenib in patients who already failed temozolomide. Okay, let us not go into the second part, but yeah, the first part, of course. Would like to have your comments on the usage of FOLFIRI and VEGF combination with or without trifluridine in the treatment of refractory MCRC.
So I'm not aware of any data with that combination. The Lonsurf is just a different fluoropyrimidine.
Yes.
So I personally am not aware of any data in that combination.
Sure. If anyone in the audience is aware of anything. Okay. The next question is, what is the role of irinotecan in second-line settings?
Yeah, in Thailand, our practice is first line we begin with oxaliplatin base, and after that we switch to irinotecan as a second line plus bevacizumab or anti-EGFR if we didn't use in the first line. It's our traditional practice in Thailand.
And we also mostly start with oxaliplatin as the first line. Then we switch to irinotecan as second line. And then bevacizumab will usually use it either in the first line or also beyond when the patient progress, also will still put it on the regimen.
Okay. Do we have any more questions from the audience?
According to some research that I read in the past, irinotecan will be more effective for oxaliplatin resistant than the reverse. What I mean is, if you use irinotecan before oxaliplatin, usually if there is failure, it doesn't respond well to oxaliplatin like there will be response to irinotecan when oxaliplatin fails. So irinotecan is better as a second line than oxaliplatin, according to a research I read in the past. Thank you.
Okay.
So we often start with oxaliplatin at the same time before.
Fair. Thank you. Thank you all. I want to thank all of you and Professor John. Thank you, everybody. Here we come to the end of the question and answer session. And I now hand over to marketing team for the closing comments.
So as you come to the closure of today's webinar, like sequencing and synergy, maximizing irinotecan-based therapy with bevacizumab for the treatment of colorectal cancer, I would like to extend really my sincere gratitude to our expert speakers, panelists, for sharing their valuable knowledge and clinical expertise and practical perspectives. We sincerely thank each one of you for your enthusiastic participation with thoughtful insights and commitment towards advancing excellence in colorectal cancer care. Your engagement has made this scientific event both meaningful and impactful. We hope the knowledge shared today supports informed treatment decisions and inspires continued collaboration in delivering the highest standard of care cancer patient. So continuous learning and multidisciplinary dialogue remains essential as the cancer treatment landscape continues to evolve. In this regard, requesting all more than 700 participants to scan the QR code on our screen to provide your insights for post-survey questionnaire before you log out from today's scientific event, please. On behalf of the organizing team of Electrolabs, thanking you once again for joining us for this scientific event. We look forward to welcoming you to our future continuous education initiatives. Have a pleasant day. Thank you very much.
Thank you all. Appreciate you all joining in, giving us your precious time. Thank you.
Thank you very
Thank you very
much.
much, everybody.
Bye-bye.
Bye-bye.
Bye. Thank you much. Bye.
Thanks. Bye.
Thank you, dokter. Thank you, Dokter
Ya,
Andika.
terima kasih, Mbak. Ya, terima kasih.